I need a volunteer. Somebody want to volunteer? Whoever. She's closest, she's gonna come be the volunteer. Alrighty, everybody will get their turn. Don't worry about that. Now, I have my otoscope and ophthalmoscope, but I'm gonna need instruments. I need a blood pressure cuff. You're gonna give it to me, Miss Kirk. Wait, I'm trying to remember your first name. Alright, thank you. And I need a tongue blade and a couple specula. And while you're hunting those, I am going to get something for nasal patency. I need a visual acuity chart.
I was voting for you.
I told her I was one in my car like an hour and
Who that?
I know. I tried to remember too.
Visual acuity chart. Tuning fork. High pitch tuning fork.
yeah, just one second. You have to put it Right? Is it on? Yeah.
Yeah, does anyone have the fancy?
Alright. Did you see what I did here?
You laid it all out for yourself.
I laid it all out according to what I'm gonna do next. That's a really good habit to get into. I was thinking, okay, I'm gonna do the skin exam, the vital signs, things. What do I need? I need my blood pressure cuff, so I'm gonna put that handy. And then I'm gonna do the eyes, so I need the eye chart. Ears, so I have my tuning fork and my ear speculum. Nose, so I have my nasal patency and my nasal speculum. And then the mouth. So I have everything laid out according to what I need in some semblance of order. And then as I use it, I put it back. I'm gonna give it back to you because they're all her things, pretty much. But it's a handy way to not forget anything. And when you're doing the complete head to toe at the end of the semester, it really is helpful because you're doing so many things. It's easy to forget an entire section because you're anxious and you're sweating and so much is riding on it, and it's just easier to just put everything out and have it and put it away as you use it, so you'll know when you get to the end of the exam, if your tuning fork is still sitting there, oh man, I forgot to do the Weber and the Renee. So it's a good way to just jog your memory, and I've done it for years. So just put everything out, and it makes it, you're still going to forget things, everybody does. I'm going to forget something today. It's just normal for you to do that. But at least this will keep you in some semblance of order. So we're going to start with the general survey, vital signs, and skin exam, so we're all on the same page, since there just happened to be some confusion with that. So then I'm just going to move right into the HEENT, so I'm not going to reintroduce myself and all those kinds of things like I'm going to ask you to do for each exam. So we'll start by introduction. Hello, I'm Mrs. Patch. I'm going to be doing your general survey, your vital signs, your HENT exam, your skin exam, and I'd like you to take off your socks and shoes and shirt, please, while I wash my hands. And throughout this examination, I am going to demonstrate professionalism. had to revise the schedule. Make sure you look at that. There's another group that's going in the morning. So, and don't forget, you're all going to meet in the classroom. And then we'll come and get you from the classroom. Come, if you're at 8 o'clock in the morning, just come dressed in your attire like you are right now. To bring your other clothing with you. Okay? All right. I'm going to start with the general survey. I'm looking at my patient. I'm noting whether they seem to be in any distress, what their facial expression's like, any obvious deformities, their level of consciousness, is their stated age and their apparent age similar, whatever else is on that whole list of things that you have. Is that pretty much all of it? Okay. Then I'm going to do the vital signs. So let's pretend I have a thermometer in my hand, and I'm going to put the little plastic wrap on the thermometer. I'm going to put it under your tongue and keep that, and I'm going to wait until that beeps. In the meantime, I'm going to take the pads of my index finger and my middle finger and find the radial pulse. I'm going to count it for 30 seconds. And this is going to go beep, 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 beep. And I'm going to take it out and look at it while I'm still counting and doing 30 seconds. You can do like 3 things at once within reason. And we're going to say 30 seconds is up. When that 30 seconds is up, I'm going to keep my fingers there and I'm going to shift my gaze to her chest and watch the respirations without the patient knowing that, because if the patient knows it, they're going to alter the respiration. So I'm going to note her respirations for 30 seconds. 30 seconds is up, I'm going to multiply that by 2. Now we're going to do her blood pressure. First I'm going to find her brachial artery. You'll notice on this is good. This is one of the ones I was telling you about that's a little bit tough to see where the bladder is. The bladder is always where the where the rubber hose is. And the bladder on this one goes from here to here, right where the seams are, where there's melded together. So this is what you're going to do your 40-80 rule, all right? Because this is the bladder. So I want to say this is the width of the bladder. You can sort of see it right there. That's the bladder. I want to check the width of the bladder to see if it's around 40%. That's pretty close. Yep, this should be good. Then the length of the bladder, which is from here to here, needs to be about 80% of the circumference of the arm. So this should be good on her. Don't worry about this. Don't worry, don't be obsessed about where this little thing is. The main thing is where the arrow is. Don't worry about it. As long as you get this, the gauge, where you can see it. That. About an inch above the antecubital fossa. First, I'm going to do a palpable systolic. So get her pulse again. Keep this hand up at about heart level. Close it off and pump it up till I can't feel the pulse anymore. Note that number, and then let all the air out. All right, put your arm down. Now we're going to do the blood pressure with my stethoscope. A word about stethoscopes, because I know there's some of you in here who have never used one before, other than maybe last week in lab. The ear pieces should be forward, should be pointing forward. Some of you, it's still straight. Just bend them a little bit. You can do that. They'll bend forward. So that's more comfortable and you can hear better. You're going to use the diaphragm to check the blood pressure. You can change it from diaphragm to bell just by clicking it backwards and forwards like this. So if you have it in your ears and you're not hearing anything at all and you think you should be hearing something, then maybe you have it on the bell instead of the diaphragm. I always check. Every time I put this on, I just tap it. If I can hear it real well, or if I can't hear it, it's on the bell now and I can hardly hear it doing this. But then I know I just need to turn it and just tap it like that. Does anybody still have on the bell of their stethoscope, do you still have this? Yeah, we need to fix that. Remind me today.
Yeah, I can take it off. I didn't know if we were
Okay,
keeping it on or
yeah,
not.
you want to take that off. You just peel it off. If anybody needs to do that, let's do it right now so everybody can see how to do it. Look at your stethoscope and see. looks okay. I had a couple in the other. Good, we need to do hers. So if it looks like this, on the bell side, where it has this film over it, this is your pediatric diaphragm. So we're gonna take it off for now, but don't lose that. Put it back in. So you just have to peel this off. Just get your fingers underneath that edge, which isn't always easy to do. There we go. And you take that. There we go. Take that off and take this off. And then does it have the wider?
I don't have it with me.
Okay. And then you would put the wider piece of rubber on there that looks like this, which came with your stethoscope. So just put that on this other rim, and then that becomes your bell, which we'll need for cardiology. So that was everything about stethoscope. Oops. That's all right. We'll fix it. All right. So I know what her number is for her palpable systolic. So now we're going to find her blood pressure. So we'll put the arm up about heart level. And I'm going to pump it up about 20 millimeters of mercury above what I got for the palpable. And then listen for a quarter cough sounds. Let the air out slowly, noting the first quarter cough sound. They continue on. I note the last one. And I continue on for about 20 more millimeters of mercury, listening for an auscultatory gap. And then I can let it out. So you want to remember those two numbers. I'm sorry if I was shouting. You don't know what you're doing when you have the thing in your ears. Then we're going to do the other arm.
I have a question.
Yep.
So does gap, you can only hear the gap after the diastolic number, after the last
The gap,
sound?
the only thing the gap is, you're listening for it if somebody has an arrhythmia. Let's say every fourth or fifth beat, they skip 3 beats. You're going to be listening to the blood pressure, and you're going to think that that's the last, no, that bottom, that's the diastolic. But in actuality, it's just that their heart is skipping those 3 beats right then. You don't know that unless you listen for a little bit longer. So if you listen for a little bit longer, and then all of a sudden you start hearing the sounds again, that's an auscultatory gap. So use that bottom number, the very last number that you hear. So you want to listen that few more millimeters of mercury just to make sure there's not an auscultatory gap. The gap, you don't hear anything. It's just that the numbers would start again.
So
if
if you find one of those, would you report it 150 over 90 with a gap, an auscultatory gap from 100 to 112?
No. If I found that, I would use the second number, actually the third number as the diastolic. What I would note is I would check the pulse again and see if that's something that was just a freakish thing that happened,
So
or if this happens over and over again.
So you don't have to report the number where the gap is. Okay.
Not necessarily.
Okay.
Maybe if you were in a cardiology thing, you might want to do that, and if it happened over and over. But that's why you want to listen for a little bit longer, so that you don't miss that. And it would be very easy to do if you do it too fast. People take blood pressure way too fast. You've been in offices where they do it in 20 seconds. Well, there's no way that you can hear it in 20 seconds. Listen to it and really get a good blood pressure reading, because it might make the difference between starting somebody on medication and not starting somebody on medication if you do it properly. So then I'm going to move on to the other arm and do it. And then I'm going to put the patient in the supine position and have them lie down for 1 to 3 minutes and do both arms again. And then I'm going to sit them up and let them sit there and make sure they're okay before I have them stand up. And then I'm going to have them stand up, and that's your third position to do it in that way, right? And do them all unless the proctor tells you to defer it. I might want you to do all 6 because you're fumbling around with things, and I can tell you've never done it before and you haven't been practicing, and hey, we're going to take this time to practice. So I might want you to do it all 6 times, so just keep doing it until we say defer. If we say defer, then you can go on. That make sense?
Do you
Yes.
Do you want us to actually wait? You said we don't need to wait the 3 minutes between each.
No, cause that eats up your time in a time test. So just say I would wait 1 to 3 minutes, and that'll be good, but normally you would, in real
Right.
practice you would.
And you want us to check the palpable every time when we switch between
I
arms?
would check the palpable once on each arm.
Okay, and then, but not when we change positions?
And when you change positions, I would ask the proctor, whoever in there with you, would you like me to do the palpable systolic again? And they'll say, if they aren't sure that you know what you're doing, they're gonna say, yes, please do it. So always ask. Then you never have to wonder.
We could do it in any order, like temperature first, the same way you did it?
You can do it as long as it makes sense.
Okay.
And do you want us to actually count the pulse then for 30 seconds, and then the respirations for a real 30 seconds?
Do it as you're saying it, yes. Say, if you say you're gonna do it for 30 seconds, do it for 30 seconds, and I might tell you, okay, 30 seconds is up.
Okay.
After 10 or 15
Is it
seconds.
okay if we say what we're doing before we do it? Like, if I wanted to say.
No, you need to be talking and doing at the same time. It's not so important for this one because this one goes really quickly. But when you get to the head to toe, if you've developed that bad habit, you're not gonna get finished. So do it talk as you're doing it. It seems very awkward at first to be talking as you're doing it. And you would never do it in real clinical practice, just as you will never say, and I will act in a professional manner. No, you're not gonna say those things, but for what, now while you're learning it, talk and do at the same time. It'll get you in the right habit so you'll be able to get it done in the right amount of time. Any other questions about blood pressure? So we did general survey and the vitals, right? Thank you. I'm gonna move on to the skin exam. I'm going to combine a little bit of the HEENT with the skin exam because might as well and get it done. So I'm gonna start with the skin exam all the way up on the scalp. I'm gonna look at the scalp and look at the skin of the scalp. While I'm there, I'm noting the hair texture. I'm looking for a rash, any masses that might be there, any nits, hair growth pattern, noting the texture of the hair while I'm there. And then I'm gonna look at the skin everywhere. That means I'm gonna have to lift hair out of the way, look under arms. If you tell me you're inspecting the skin and don't move things, I'm not gonna believe you. Look under the knees. And at the very end, I'll look between the toes. Don't forget to look between the toes, that's where things like to hide. I'm gonna look behind the ears. Remember we talked about things that like to hide behind the ears? And look at the skin of the back. Then I'm also, while I'm inspecting, I'm looking for rashes, masses, lesions. I'm noting the color of the skin, anything that wouldn't be expected. I'm gonna palpate the skin, noting the texture of the skin, especially if I see any rashes. I'm gonna palpate rashes unless they're oozing pus or they look like impetigo or something like that. I'm gonna palpate it without gloves. I'm also gonna look for cyanosis while I'm looking at the skin. Then we're gonna check the temperature of the skin with the backs of the hands. I'm gonna do both arms at the same time, both legs at the same time. I'm noting symmetry. They should feel the same on both sides. If one side feels warm and the other side feels cool, I'm worried about the side that feels warm. Is there an infection? Or maybe the opposite. I'm worried about the side that feels cool. Why is it cool? Is there an arterial occlusion somewhere? I want to think of all those things, but both sides should feel equal. Then I'm going to note this turgor. So I'm going to take a little pinch of skin all the way down the arms and just put your hands down like that. And I'm going to go on the backs of the hands to note the turgor on the skin, see if there's any tenting. And down the legs, same thing, see if there's any tenting. I'm going to do it on the tops of the feet. So that's assessing turgor.
Is it common to have a difference in turgor between different parts of the body, or I mean, it's
Probably going to be about the same.
I mean, is there a reason to do the whole body?
Just so you don't
Just-
miss something. Yeah. You want to, the skin, you have to look everywhere. That includes the lips, everything, which will be part of the HEENT exam. that everything? Did I forget anything on the general survey, vitals, and skin exam? You tell me later if I did. Alright, we're gonna move on to the HEENT. I already looked at the scalp, noted the hair texture. I'm gonna palpate the head, note the contour. I'm also gonna palpate the face. While I'm here, I'm gonna palpate the frontal sinuses and the maxillary sinuses. I'm gonna palpate the lacrimal glands, which is in the eye part, but if I don't do it now, I forget. So that's the lacrimal apparatus, and then in the lacrimal ducts. Good. And I'm also noting any deformities that I might see in the face. Symmetry. You're always noting symmetry. We look at one side compared to the other. Is it swollen on one side and not swollen on the other? We'll move on to the eye exam. First thing I'm going to do is visual acuity. Do you have contacts? Do you wear contacts or glasses? Okay. So I'm going to hold this about 14 inches away, and I want you to read the lowest, cover one eye without pushing on your eyeball. Read the lowest line you can read.
5, 6, 3, 2, 9.
Okay, drop that hand, put the other hand up, cover the other eye. Read that line backwards.
7, 9, 2, 3, 6, 5.
And can you read the line below that?
6, 8, 3, 2, 7, 9.
Okay, so she can read a little bit better on that eye, but have them read it backwards. So that's visual acuity. Next, we're going to check extraocular movements. So I'm going to trace an H. I want you to watch with your eyes, but don't move your head. Okay? You're noting the even movement of eyes. It should be without any hesitation, and both eyes should move together. Now I'm going to note the extremes of gaze to see if there's any nystagmus. I'm not watching my finger, I'm watching her eyes. And just hold your finger at the extremes for a few seconds to note any beats of nystagmus. Now we're going to do accommodation and convergence. Just look in the distance there. Now look at my finger and watch my finger come in. I'm noting pupillary constriction and convergence of the eyes. That's accommodation. We'll do the fishbowl one next, the visual field. Close your right eye. She's going to close her right eye. I'm going to close my left. I want you to tell me when you see both hands, the fingers wiggling, okay? Okay. My nose, that's all right. Okay, now the other eye. You're going to do the same thing with the other eye. Now, when you're the examiner, you have both hands out here. You're going to see them. She doesn't, but you do. But when you move them around to the side, you're going to, I had my left eye closed. I'm not going to be able to see this one moving until she sees it. And that's how you can test if hers visual fields are similar to mine. So do both eyes. Check both eyes with that one. All right. Now we'll start shining the light in the eyes. First thing I'm going to do is have you stare straight ahead, and I'm going to check the anterior chamber with oblique lighting to see if there's any shadow on the iris and to see if the anterior chamber is clear. All right. Now we're going to check pupillary constriction. I'm going to look for direct constriction. Now I'm going to shine it in that same eye, but look at the other eye to see if it constricts. Okay? And we're going to do the other one. Direct and consensual. Okay? This is getting a little dull. Is it?
Yeah,
Those things don't look.
Yeah.
Huh.
Because mine's like that too, and I just took it out of the box.
Me too.
Huh. Can you put batteries in them?
Is that the one with the pupils on the side?
Yeah.
I just love that one too.
It just looks dull to me.
Is it this like this? No, yours is right.
Yeah, yours was
No,
right.
no, I thought.
Oh, I just feel like it
Like for $5.
This like looks like an LED.
Yeah.
Pretty good.
Wherever you got it, ask him, tell him that the battery's almost dead and you just got it. don't see any place here where you can do it. Yeah, that happens sometimes. Okay, now we're gonna check with the ophthalmoscope. Would you darken those, curtains for me, please? Just close them.
Oh,
There we go. Close them all the way. That'll help. You need it as dark as possible to be able to see. All right, this is the most difficult instrument to learn how to use properly. So here are some tips. Every instrument's going to be a little bit different. This one, to turn it on, you push down on the green thing and slide it over to the side. And then you want to see which light you're going to use. And on the front, this one changes by, I'm shining it there so you can see. There's a little aperture, there's even a smaller one, there's the green one, there's a slit, and there's a gauge. I'm going to use the big one, all right? Have the patient look straight ahead. My left hand, I'm going to take my glasses off in a second as soon as I see what number I'm on. I'm going to start at 0. I want you to start at 0 until you know what number you need to be on. And then you're going to focus it. I focus it on my hand because that's the easiest thing. Focus it so that the lines in your hand come in nice and crisp. That's how you know where to start. This one says green 6. So that's where I'm going to start on mine because I know that's where it's going to be normal for me. Now, keep your finger on this diopter. Every time you move this, it changes the lenses. And you're going to have to move it several times to be able to see the vessels. Put your opposite hand on the top of the head, take your thumb at the eyebrow, and lift up on the eyebrow just a little bit. That does 2 things. That helps get the eyelid out of the way, plus as you're going in a little bit closer with the patient, it helps you to know not to get too close. Right hand, right eye, right eye. Look straight ahead. I'm looking for the red reflex, which I can already see it way out here, and follow that red reflex in until you can see the vessels. I've changed the lenses about 5 times already, just to get it focused, and now it's nice and focused. I'm finding the optic disc. There we are. Now look into my light. Okay. When you have them look into the light, don't hold it there. It hurts. You'll find out pretty soon. So don't hold it there. Just have them look in it, and you're looking for that glow of Venus. That's what I think it looks like. It looks like, if you don't know what Venus looks like, you need to get out more. It looks like a planet. It has that glowy, sparkly look to it, that whitish planet look. Then I'm going to switch eyes. Look straight ahead. Left hand, left eye, left eye. There are the vessels. There's the disc. Look into my light. Good. Did you notice how I moved as one unit? It all reminds me of that robotic, that robotic dance. They do that. You're all one unit. Your hand, your eye, your instrument, your body are all one unit when you're using this. So you just move as one. I'm going to show you how to do it incorrectly. It's very hard for me to do it incorrectly because I've been doing it right for a long time. But I'll show you what happens when you do it incorrectly. I'm going to use the wrong hand. I'm going to use my right hand on her left eye. First of all, it feels very awkward doing this. Look straight ahead. I can do it. I can see it. But to be able to see what I need to see, what did I just do?
You have all of your space.
Yeah. We're like we're kissing cousins. You don't want that. Your patient doesn't want that, I promise you. So be careful on how you're using that. So that's the ophthalmoscopic exam. Is that all? Oh, you know what I didn't do? I didn't look at the conjunctiva. I didn't inspect. Look up at the top of your head. Okay? Good. And look at note the color of the sclera. Didn't do that. Anything else I forgot in the eyes? Okay. We're you don't have, we're not gonna flip the lids until next semester. So you don't have to worry about that yet. Alright, we're gonna move on to the nose. Alright, check the patency first. You can do the ears or nose first. It doesn't matter which you do next. Occlude one of your nostrils for me. Blow one. Good. Now the other one. Blow one. You're just noting that there's movement there, that she can breathe through both sides of her nose. Look at the nose, note the symmetry. If the septum seems to be one side or the other, it can be a little bit off, but if it's way over one side or the other, you know there's going to be problems. Take your speculum, tilt your head back just a little bit. Doesn't matter which hand you use for this. And make sure when you put this in that you don't hit the septum. So you sort of make the light shine out toward the lateral aspects. And you're just looking in there for polyps and any discharge that would be not supposed to be there. I'm going to move that there for now so I know not to use it again. Alright, now I'm going to move on to the ears. First thing I'm going to do is check your hearing. I'm going to occlude this ear. Well, I'm just pushing on the tragus so she can't hear out of this ear. And I'm going to whisper something and tell me what it is. Okay? Make sure she can't read your lips. I had somebody in the other class ask me, they said when they had to do like a DOT physical, they had the person standing on the far side of the room. There are different requirements depending on what you're doing the physical for. But for this purposes of this, you can do it that close. And if that person doesn't hear it, whisper a little louder. And then it's just a real vague screening kind of thing. So then, if there were a problem, we're going to do the Weber and the Rene. This is the tuning fork I want you to use. This is your high-pitched tuning fork. Don't hit it on the metal part of this thing. It clangs and scares people, and it's not good for your tuning fork. So hit it on, some people hit it on their hand. I think that hurts. I don't like to do that. Some people do that. I'll just hit on the end of this. Okay. I want you to tell me, do you hear that in both ears equally or one ear over the other? Don't hear it at all, and that's not unusual because there's a fan going and all kinds. If you were in a soundproof room, you'd probably hear it. So that's the Weber. You hear that? Hear it? Tell me when it stops. Can you hear it now? Yeah. So that's the Rene. As long as she can hear it after I move it off of her mastoid. Remember, don't put your finger up on this. That'll stop the sound. Then you have to do the other ear. Hear that? Tell me when you don't. Hear that? Okay. Alright. That's the Weber and the Rene. Now we're going to take a look at that. Both ears. This screen is a magnification. On the ones that are like mine, you only have one magnification. The newer ones, the ones with the longer, the longer ones, you can move that so that it could be more magnification or less magnification according to what you want. So it all depends on which instrument you have. So turn it on again. Now you're going to have to make the ear canal as straight as possible. With adults, that means you're usually going to have to pull up on the auricle a little bit. Take a look in there. Look at the canal. And note the condition of the canal and the tympanic membrane, noting the umbo, the pars flaccida, the pars tensa. And the other side. Here I'm going to palpate and look at the auricle and push on the tragus to see if there's any tenderness. Okay. And I already checked earlier about the firmness on her face with the maxillary and the frontal sinuses. If she said there was any pain on any one of those places, we're gonna try to transilluminate the sinuses. So to do the maxillaries, we'll do here, open your mouth. Oh, I actually can see a glow on hers, even with this weak battery. You're looking up the top of the mouth to see if you can see that reddish glow. On the frontals, I'm gonna put it right against the edge of the eyebrow. And I'm not seeing it, but that doesn't mean that there's an issue. It just means that some people you can see it better than others, but always check. We'll find somebody in here. Whoever's the fairest, maybe Anna, you might be able to see on Anna.
Is there any utility to percussion over the sinuses?
If it's tender to palpation, it's gonna be tender to percussion, and it's not gonna make that much difference. This is just a very basic screening exam. You're not usually going to do that with today's methods that we have, but I think it's always good to know how to do some of those things that we haven't done for a long, long time. So that's the nose, that's the ears, that's the eyes. Yes.
For the ear exam, is it okay if you put your for the hand you're using? Is it okay if you put your hand on their face so you don't? I remember you said in class.
When we do the pediatrics, I especially like to do that. So you use your hand as a fulcrum. You're going to do it like this, so that I'm protecting the patient. I'm going to hold it like this. It's easier with my instrument than it is with or you guys move if you can't see it. Make sure you can see everything. You're going to have to. You still can't see. So that you can move it in and out like that without making it go in too far, and you're protecting your patient. That's using your hand as a fulcrum. We'll work more on that when we have pediatric exam. All right, we'll move on to the mouth. First, I'm going to inspect, note the lips. This is when you get to wear your gloves. All right. And I want to see inside the mouth. So open your mouth for me. You're going to use your tongue blade. Boy, this is almost dead. That's a shame. You just bought it. Look at the buccal mucosa. Looking at the roof of the mouth, the hard palate, the gingiva, the teeth. You use your tongue blade to move things out of the way. Lift your tongue up for me. Looking under the tongue. Okay, stick your tongue out. Say ah. Good. You're noting the symmetrical rise of the posterior pharynx and the rise of the uvula, and noting whether the uvula is in midline. Good. Now, once you stick your tongue out for me, now we're going to palpate the tongue, which seems really weird, but you're especially going to palpate the edges, and you're just going to take your finger and push on it a little bit, and just to see if you feel anything hard. If you feel anything that feels hard as a rock, you're worried about it. You're worried that that's a cancer of some sort. And hardly anybody ever does that, but you do it. You might pick up something way sooner than wait for the nose to get involved. All right, and you stuck your tongue out, so we saw that. All right, now I'm going to feel on the inside of the mouth. I'm going to feel the Stenson's ducts. I also looked for them while I was in there. You're going to feel where you saw them, where the little hole was that you saw, and I'm going to feel on the outside and the inside and sort of rub my fingers back and forth to see if you can feel a stone. With that same finger that was just inside her mouth, I'm going to feel on the other side for the Stensons. Then lift your tongue. I'm going to feel underneath the tongue toward the front for the Whartons. Good. Watch how I take my gloves off. Take this one, pull it inside out. Then you grab a hold of it and pull this one inside out. Now, anything that touched the inside of her mouth is on the inside of this glove. So if you don't have a wastebasket right there, you can throw it down and it won't hurt anything. All right, we'll move on to the neck. First thing I'm gonna look at is the trachea to see if it looks like it's in the midline. Tilt your head back just a little bit. I'm gonna palpate the trachea. And I'm gonna look for and I'm not gonna be very nice because I don't have a glass to give her a container of water. It's much easier if they have water, but I'm gonna ask you while your head's tipped back a little bit to swallow for me. I'm looking for her thyroid. Hers is easy to see. So you see the thyroid cartilage, the cricoid cartilage, and then right below the cricoid cartilage is her thyroid. I like to palpate it from the back. There's her thyroid cartilage and her cricoid cartilage, and just below that is where you're going to feel her thyroid. Swallow again for me. I'm being a mean PA. There, I can feel it very easily. It's not large, but you know it's there. You can feel it. All right, now we'll do her lymph nodes. Her preauricular. Just take the pads of your fingers right in front of the tragus, preauricular. Right behind the ears, near the mastoid process, the postauricular. Occipitals are right behind that, not all the way in the back, but toward the sides of the back of the head, or the occipitals. Tonsillars, right where the tonsils are. Submandibular, halfway up toward the chin, and submental, right under the chin. Posterior cervical chain are right behind the sternocleidomastoid. The anterior cervical chain or superficial chain are right in front of the sternocleidomastoid muscle. To feel the deep cervical, it's best if you have them tilt their head, so tilt your head to the side, either side. Whichever side her head's facing toward, that's the side you're going to feel, because you've just made the muscle movable by doing that. So you can feel behind that muscle to see if there are any nodes. And then switch your head the other way, and you can move that muscle forward and feel right underneath there.
Are you moving the back side of the muscle? To
Yeah,
get to
I'm
that?
moving the back side of the muscle forward so I can feel underneath that muscle. That's exactly what I'm doing.
Thank you.
I'm pushing it forward. And then the supraclavicular right over your clavicles. It's best to feel that when the patient takes a deep breath, so take a deep breath for me. And see if you can feel that superficial chain. There are a lot more lymph nodes than that, but those are the ones we're going to do for the HEENT. There's ones involved that if you're worried about breast cancer and things, you check the epithelials, the others. Did I forget one whole big section? Did I forget anything? Any questions before I let you do it on your own?
How much of the lymph nodes should you be able to feel?
You shouldn't feel any of them, really.
Okay.
Unless somebody's sick, you're not going to feel any of those lymph nodes, but you still have to check.
Okay.
Yeah, you're not going to feel anything unless there's an abnormality.
Okay.
All right? Okay, go to it. Thank you very much for your help.